Good afternoon, everyone. Thank you so much for joining us. My name is George Koulianos, and on behalf of the Medical Association and our Alabama physicians, welcome to today's timely program entitled Discussion on Respiratory Illnesses. We have a wonderful group of speakers today. Dr. Michael Saag is the Associate Dean for Global Health in the School of Medicine and Director of the UAB Center for AIDS Research, as well as a full professor of medicine in infectious disease at UAB. Dr. Linda Hassouneh is an experienced pediatric infectious disease doctor on the faculty at the University of South Alabama. And Dr. Karen Parsell is a pediatrician intensivist at the University of South Alabama. Dr. Saag.
Great. Thank you very much, George. It's great to be with everybody today. We're going to cover three respiratory viruses that tend to increase in incidence and prevalence in winter months, which is right upon us now. So I'm going to start off with a brief overview about what's happening in COVID, and then we'll segue over to respiratory syncytial virus, RSV, which we're hearing a lot about because of the new vaccines. And if we have a little bit of time at the end, we'll just talk briefly about influenza. So I'll kick it off here on COVID. We have been experiencing rolling waves of infection, nothing terrible. As you remember, back around the first of the year or end of last year, Omicron variant came up, and there's been several iterations of that. What we know about Omicron is that it is a little bit more infectious, meaning more people, once they're exposed, will pick it up and get sick. But fortunately, the illness itself does not appear to be as virulent or as bad for the most part. The population who we're still worried about the most are the elderly and those who have a compromised immune system, meaning that they're on medications. And one that I'm seeing that pops up a lot is rituximab or CD20, anti-CD20 antibody therapy, which is used a lot in medicine for some cancers, but also for some rheumatologic disorders. The problem there is that anti-CD20 blocks the production of antibody. And typically what will happen in that setting is somebody will get a respiratory illness with COVID, test positive, maybe or not be treated with Paxlovid, do better, and then have a relapse at week 3 or 4. And they'll come in, people think it's a respiratory bacterial infection, but on bronch and other things, it's actually just COVID. And retreating them with antivirals at that point using remdesivir will be very important. So immunocompromised folks and older folks. Does it mean that younger folks aren't being infected? No, they sure are. But for the most part, their illnesses are more self-limited. The question that comes up a lot is, okay, if I've got somebody over the age of 50 or 60 and they test positive for COVID and they're otherwise healthy, should I treat them with Paxlovid or outpatient remdesivir, harder to get, but let's just focus on Paxlovid? The answer is, in my opinion, yes, we should, unless there's a contraindication to using Paxlovid because of the use of the ritonavir, which causes drug-drug interactions. Why do I say that? Because in the first 2 to 3 days after infection, there's a huge amount of viral replication. And these drugs work best if they're used within 24 hours of onset of symptoms, 48 at the max, when that replication is really taking off. And that'll shorten the duration of illness and reduce the severity. If you wait until day 4 or 5 after onset of symptoms to start the medication, it doesn't work as well. So what we're hearing in the community is, while I was on Paxlovid, it didn't do much. But you find out when you ask, oh, well, when did you start it? And they say, oh, my 6th day of illness. Not going to work. So if you have somebody who newly diagnosed, you should have them call your office, get them started on the Paxlovid, especially if they're in an older age group, and really especially as well if they're immunocompromised. If somebody's got significant immunocompromise, meaning transplant patients or especially people in the hospital, then remdesivir IV is the way to go. The other question that comes up a lot is, what's new in the vaccine? Should I get it? This current vaccine that came out in September is really the best vaccine we've had and is on par with our original vaccine. If you remember back to December 2020, when the COVID vaccine was first released, we went for about 6-7 months with very few symptomatic infections. It wasn't until July of 2021 that we started seeing cases of symptomatic COVID among people who were vaccinated. And that's because that was the beginning of the Delta wave, if you remember that. And that was significantly different, such that the vaccine did not provide as complete protection against symptomatic infection, but it still, and has ever since, protected us against hospitalization and death compared to people who never were vaccinated. So several iterations have followed, but this current vaccine has got all Omicron variant. And so there's no longer the original variant that isn't around much anymore, but it's all about the XBB variant. And there's two different types. It's going to be much more effective and perhaps reducing symptoms again, as long as Omicron stays with us, which is currently the case. So I think we'll get into some Q&A later. I think that's just a good way to kick off what's new. Our cases really reduced in October dramatically in terms of hospitalizations and deaths, but starting to pick up again. And the question is, will we start spiking post-Thanksgiving, post-Christmas, like we've done the last several years? Answer, probably yes. But we'll cross those bridges as we get to it. So we're going to cover now respiratory syncytial virus. And Karen, I may turn it to you to kick us off and maybe just give us a broad overview of what is this, what does it look like clinically, and what kind of trouble does it cause, especially young people?
Yes, of course. So many of you may know about RSV or have heard of it. I think anybody that has a child, either there's an outbreak at your daycare or your child gets sick and tests positive for it. So it does stand for respiratory syncytial virus. And so the syncytial part just means the replication that happens in the respiratory tract. And so that causes a lot of congestion. So anybody who's ever had firsthand experience with a child that's had RSV knows that it's, lots of secretions, lots of nasal secretions. There can be wheezing associated with it. And it's the most common reason that kids get hospitalized. Especially during RSV seasons, which typically in warmer climates like Mobile is year round. I mean, we definitely see more this time of year, but can happen anytime. And so what we've done for RSV is really just supportive care, so if kids have to be in the hospital, we support them with IV fluids or respiratory treatments and, things of that nature. And there really wasn't anything preventive for kids for RSV for a long time, except for our premature babies. So there was a monoclonal antibody actually called Synagis, which came out in the late 90s or 80s, I believe. And it was only approved for kids who were premature or had other risk factors, because those kids definitely, could have a worse case if they got RSV. But if you actually look at the number of children who are admitted with RSV who require hospitalization, of course, it's across the board. It's not just premature babies. So historically, there was never really a good way to kind of make it still an effective vaccine, but cost effective to give to all of our babies like we do with other childhood immunizations. And now there's a lot of exciting vaccines or antibody treatments to help prevent transmission of RSV. So we have for healthy babies, even, within the first week of life can get it. And it's a one-time thing. We have it offered for pregnant women in their last trimester to help them build up antibodies that transfer across the placenta to help protect babies, and even for our patients who are 65 and older, which I don't take care of, but as I have family members that are that age, I'm very happy that there's a vaccine because it's not just our babies that can have serious illness from it, it's the elderly population as well. And some people may think it's just a cold, but then they end up in the hospital and require respiratory support with oxygen, ventilatory support, and things of that nature. So it's very exciting. And I'll let Dr. Hassouneh kind of take over and talk about why now we have these options.
Thank you. Thank you for having me. So yeah, as Dr. Parsell had mentioned, we have a lot of experience with pembrolizumab, and we usually use it in premature infants, especially less than 29 weeks. But now we're excited because we have two measures that we can use to prevent disease in infants. And as Karen had mentioned, that this is the #1 reason for hospitalization in children. And during the winter season, especially from October to March, we see a increase in hospitalization, and this puts an increased strain on our healthcare system. About 2 to 3% of infants will be admitted, hospitalized for RSV. So you can see the impact of RSV that it has on hospitals. So I'm really excited about this. So nirsevimab is the name of the new monoclonal. And the difference between nirsevimab and pembrolizumab is that it's long acting. So you only need 1 dose, while pembrolizumab we used to have to give monthly injections. Nirsevimab is given once, and the recommendation over the summer when it was approved is to actually give it to all infants in their first RSV season less than 8 months, and then those from 8 to 19 months in their second season with high risk. It's good news, but unfortunately we are facing a shortage. So the company will not be able to provide doses to all of the infants that were initially under the recommendation. So the CDC has given out recommendations to try to optimize the use to those that are at highest risk. So those that are under 6 months of age, and then American Indians, Native Alaskans less than 8 months of age, because we know that they are at increased risk of hospitalization. Some studies say up to like 4 to 10 times more likely to be admitted to the hospital when you're American Indian or Alaskan Native. So that hasn't changed. You're still, the CDC would like for those kids to get nirsevimab. And then those that are from 6 to 8 months that are just at really high risk of complications, such as heart disease, chronic lung disease, immunocompromised patients. Right now in our hospital, we have already started to give the monoclonal, and we are giving it primarily to those that are leaving the hospital from the NICU. But luckily today I understood that we did receive our shipment from the Vaccines for Children program. So we are trying to open it up to all of those leaving the nursery as well. I forgot to mention that it is recommended to try to give it in the first week of life. So I think it would be important for hospitals to stock this, but if the hospitals can't, the pediatricians can also order it and have it done there in the outpatient setting. I understand there are a lot of limitations this season due to shortages, and then also, so this was actually voted to be included in the Vaccine for Children program to increase equity, which the AAP considers this to be very important to make sure that everybody is able to have access to nirsevimab. But right now, the way that it is that payers have 12 months. They're given 12 months to honor this. So some pediatrician offices are scared to order it and then not receive the cost later on. So that has also been a problem. I think the cost is about, I think $495. So that sometimes is a cost to the hospitals and pediatricians' offices. So that has been a limitation this season.
So let me unpack this, because that's a lot of information. Let me see if I can summarize it. You correct me if I'm wrong. RSV is a big problem, both for adults and children, but especially in children who are premature and kind of all kids, especially in their first RSV season. So what we're doing now, correct me if I'm wrong, is you give mom in the last trimester a vaccine. Is that correct? Mm-hmm. Right? And mom produces antibody, and that protects the kid. Now, let's say a mom has had the vaccine transmitted. Does the baby still at birth get monoclonal antibody?
They can. I mean, if it's available, it's still recommended because they just get extra protection that way.
Right. But if you have a shortage and you know mom got the vaccine, perhaps that's a baby you could wait a little bit because it's going to last in the baby for what, 3 to 4 months after birth?
Correct. Yeah, 2 to 3 months.
2 to 3 months. Okay.
So
So
the recommendations currently, sorry to interrupt you, is that there's similar efficacy between the maternal RSV and nirsevimab. So right now, especially with the shortages, the recommendation is if the mother received the RSV vaccine, the baby not get it.
right.
And there are exceptions. So if the mother received it within 2 weeks of delivery, that's not enough time for the mom to mount that reaction. So yes, that would be an indication to consider nirsevimab in the baby, but also in mothers that might be immunocompromised, where they might not also mount a response, or if you feel like the baby is just at really high risk, and that's a clinical judgment that you would also offer nirsevimab to the baby. But I think AAP and CDC have now not recommended giving both at this moment in time.
Right. But a lot of times in real life, a baby comes in with a mom, and we don't know if the mom got it, and that you're going to assume mom didn't get it, and then that's where you might give it, right? So coming back to the baby, when we say give monoclonal, we're not doing an IV infusion here, right? We're doing IM injection, correct? And the dosing we can look up. We don't need to go into that now, but the pediatricians will know what to give. So when do you think there will be the vaccine available for a non-immunocompromised child instead of giving them an IM injection of a monoclonal?
I'm hopeful sooner than later.
Yeah.
With no shortages.
Yeah. Well, so you're right, because, one of the things as an adult ID doc, when the RSV vaccine came out, I thought, oh, great, they're going to have this for kids. And it wasn't approved initially for kids, but it will be. All those studies are ongoing, right?
I believe so. I don't know that anything is in the later stages. I'm unsure. That's, I guess, my answer.
Yeah,
but I'm hopeful that yes, this is very good signs that it is coming.
Right. So, Karen?
Oh, I was just saying, you mean for older kids?
Yeah, like
Yeah.
age 2 or something
Right.
like that, right? Okay. So one of the questions that I get a lot from patients is say, well, I went to my internist, they're 65 years old and they're healthy. And I said, hey, tell me about this RSV vaccine. And some of the docs are saying, you don't need it. Well, that really isn't true, because even though there's not many deaths that occur, there are some, but there aren't many deaths from RSV in adults. There is a lot of morbidity. And we can all recount stories of older men and women who have gotten RSV and remain ill for weeks, wheezing, cough, sometimes hospitalized, and this can be prevented. And so I think the side effects of the vaccine are not horrible. It's very similar to Shingrix because of the adjuvant that's used, especially in the GSK product, is the same as what's used in Shingrix, and you just get a more robust immune response. But it's definitely worth taking, and we're recommending it for everyone, as the package insert indicates, over the age of 65. And because this is also a transmitted virus in the community. So could you all talk a minute about transmission? How is RSV transmitted?
So it's highly contagious, and unlike flu and para-influenza, which can cause more of a croup type picture, that's droplet transmission. So this survives on surfaces and fomites, as we call them. So it's droplet and contact transmission. So it's and this is why it runs rampant. If one child in the daycare gets it, then by the end of the week, probably all the kids have gotten it, because it's just it's that contagious.
So the child goes home, obviously, and has RSV and is shedding, and mom and dad may pick it up, but then grandma and grandpa may be coming over and they pick it up.
Right.
And that's where the protection of those over 65 really comes into play.
Mhm.
I mean,
Or
'cause
the
I-
opposite, if a grandparent, picks it up from a church gathering or something like that, and then they go to see their brand new grandchild, then that grandbaby, has a higher risk of requiring hospitalization.
and as a grandparent myself, I can hardly think of a time I've gone and seen the grandkids. They never have coughs and they never sneeze. I'm kidding. They do that.
Right, yeah.
So I never know what it is unless I test them, but that's part of the reason for the protection. Any final thoughts? I want to finish up with influenza here in a second, but anything else that we haven't talked about with RSV? There's no treatment, correct? Once somebody gets it, they got it.
Yeah, it's supportive therapy. Like there are an antiviral called ribavirin, but it's not very effective, and it's very costly, and it messes up,
And it's given inhaled, right? It's inhaled
right,
ribavirin, which is a real mess.
right. And it doesn't show much efficacy. So typically it's only supportive care, whether that's ventilatory support and IV hydration and things of that nature.
And it can last for weeks in the hospital. So we only have a few minutes left here for the didactic, and then we'll have equal time for questions, which we're looking forward to. Let's segue to the other virus of the winter, especially, and that's influenza. The vaccine has been out. A couple of comments. Oftentimes, the vaccine is based on what happened in Australia, New Zealand, it was our summer, it's their winter. So we have a sense of what's being transmitted, and then they make the vaccine based on that intelligence. We recommend that really kind of everybody gets a flu vaccine, especially if you're in a healthcare setting, especially if you're older. If you're over the age of 65, you want to make sure you get the higher dose, better exposure to antigen, and therefore better protection overall. And we have some antivirals. I think the one we know most is oseltamivir, which we know is Tamiflu. But here's the thing: just like with COVID, that drug works best as an antiviral when given very soon after symptoms. 2 days or longer after onset of symptoms, almost forget about it. But it can do miraculous things in terms of reducing duration of symptoms and intensity of symptoms when given within just hours of onset of symptoms. So having the ability to test and find out and immediately get on Tamiflu is important in adults. What's it like for kids? Kids get influenza?
Oh, absolutely. And it is 6 months and up is when we recommend that the babies start getting their flu vaccines. And again, just like that transmissibility between adults and children, right? Help to protect our babies. So for babies under 9 years of age, if it's their first flu season, first season to get the vaccine, they get 2 doses a month apart. But after you've had that, then it's 1 dose yearly. So and again, because it changes year to year, you just build up more antibodies year to year, which means, you just have better protection every time you get the flu vaccine.
Linda, any other comments about flu?
Yeah, I just wanted to comment that I guess for all 3 viruses that we talked about, definitely those age less than 2 are at highest risk for complications. And I know, just like you said, that, individuals greater than 65, why do they need to get RSV vaccine? I really stress that to please vaccinate, those that are at highest risk. And for children, that is, yes, less than 2, but typically less than 5 years. And this less than 2 is the higher risk. So we definitely recommend it. And with all 3 of these viruses going around, I think the hospitals are going to be full, and the best means of protection that we have are vaccinations.
And one of the things, I guess, maybe to wrap up on is diagnostics. I mean, for kids coming to the ER, to a lot of doctors' office, pediatricians' offices, a lot of times they'll have a multiplex test procedure available that can test for all three of those and let you know which one's there, which is extraordinarily helpful, especially for the ones that we have treatments for, like SARS-CoV-2 and influenza. Maybe one day we'll also have a treatment for RSV. We don't have that net yet. The one thing that impressed me, I don't go to the Children's Hospital all that often, but I was there pre-COVID in like 2019 in the winter to visit a child of a person I worked with, and I was just blown away. It was in January, and there was wall-to-wall kids there. Over half were there with RSV between the ages of 2 and 5, and they're sitting there coughing and wheezing, and there's not much that could be done. It was kind of hard to look at, and the moms and dads were at the bedside. I'm thinking, oh, they're going to get it too, and it's, if you haven't been to a hospital, and a children's hospital, maybe since training, it's striking what goes on in the winter months, especially. George, maybe we'll turn to, go ahead, please.
Oh yeah, I'll just add, as a hospitalist, and Linda knows this too because she works with me. It's really rough. I mean, of course, we want to take care of babies. That's what we're here to do. But when beds are full and you have patients that don't have respiratory illnesses, that it makes it a stressful environment for everybody, because we want to provide good care and we want everybody, of course, to get better. But you only have so much space, and so trying to manage somebody in the ER, or when our patients leave from the floor to go to PICU, and then once they're stable enough to come back to us, we certainly appreciate that relationship that we have with our ICU and everybody that treats kids in the outpatient setting and in the ED. But it's the volume. And if you have to transfer kids out, to a different hospital, that makes it definitely much more difficult for the families as well. So.
True. So George, we have any questions coming in?
Actually, we have several. First, I'd like to start with, what's the compatibility between these three vaccines? Can you take all three at once, or do you have to do them one at a time?
Well, they are compatible as a rule. I recommend not getting all three at the exact same time, because the side effect profile goes up substantially. I've seen people do that, and they're more likely to get flu-like illness and be almost sometimes bedridden for several hours because of just the kick. But a lot of people are getting RSV and COVID vaccines together, or influenza and COVID vaccines together. I just wouldn't get all three at once.
So 2 is good, 3 is not.
In general, what do you think, Linda?
So for children, the flu vaccine and COVID vaccine are given for those greater than 6 months of age. So if you are less than 6 months and you're getting nirsevimab, you're just not eligible yet for the flu and COVID. And hopefully moms will always also get COVID and flu vaccines as well, because that is protective for the babies. But if they're older, so from the 8 months to 19 in their second season, the recommendation is they can get all three together.
Mm-hmm.
With all the vaccine hesitancy, I try not to recommend separating it unless that's the family's wish or preference.
That's good to know. It's important to know that it doesn't decrease the efficacy to have 2 of them at once. It's really important. So we have 3 other questions. What are the most easily recognizable symptoms of RSV, and how might it be differentiated from the flu or COVID?
Yeah, so that's a great question. So they all, of course, usually cause cough and congestion. They can all have fever associated with them. So I would say there's on all 3 can cause bronchiolitis. So that's inflammation in the lower airways, which can cause wheezing and difficulty breathing and things of that nature. So it's really hard to delineate sometimes, because their symptoms may be exactly the same, or you may have co-infections. So like Dr. Saag was talking about, doing rapid testing is very important because we can kind of delineate, exactly which infection, and if there are antiviral treatments, then we can, help tailor the treatment accordingly. So there's really not a good way to know. Some kids, when they get RSV, will only have an upper respiratory infection with nasal congestion and not the lower respiratory symptoms. But it's important to know that if your child does test positive for RSV, that those symptoms may worsen or flu or or COVID. So knowing what to anticipate and the signs of when to return for medical care are very important.
So that leads me to a follow-up question, and that is, how do you know when you should take your child either to their pediatrician or to the hospital?
So do you want to take that, Linda, or you want me? I would just say if your child is, seems to be in respiratory distress, is having difficulty breathing, even, wheezing type sounds, sometimes that's an early sign and you may need to go seek medical care for that. But also dehydration, and that happens with flu and it happens with COVID as well. So some kids, get very anorexic and they won't drink, and so they need hydration support. So if those things are happening, a fever itself is, a symptom that can be treated. So if your child is otherwise well, it may be good to get them evaluated at their pediatrician's office to determine the cause of their fever. But definitely any shortness of breath, increased respiratory rate, things of that nature, or dehydration needs to come to the hospital.
Wonderful. And does breastfeeding transmit antibodies to protect against RSV if the mom's vaccinated?
When the mom is vaccinated, it's not from the breastfeeding, it's during the pregnancy itself, not from breast milk.
Right. So it's transmitted through the placenta if a mom gets vaccinated. And moms that breastfeed, if they get exposed to one of these respiratory viruses, their body will make antibodies that will transmit to the baby. So it can be protective in that way, but a maternal vaccine would give, more protection. So it would be great if you plan to breastfeed, but also you get the vaccine.
Wonderful. And also, a week and a half ago, I was hoping I could get some commentary from y'all. There was a wonderful paper that was published. It was an open communication in JAMA on how effective masks have been at preventing the transmission of COVID.
Yeah. I might kick off in this if it's okay. It was a wonderful, it's almost a commentary. It wasn't necessarily, it was reviewing existing data. And I think there were several points. The first is that people were looking to randomize controlled clinical trials to demonstrate efficacy of a mask. And while there have been a couple of very large ones, one in Bangladesh in particular, the problem is this, that people are not, it's hard to prescribe which mask that people use in the intervention group. You can start, but they doesn't mean they're going to use that one. So an N95 works better than a cloth mask, etc. Secondly, there are people in the control group who might be wearing masks intermittently, and so it's not as pure. And finally, those assigned to getting the mask aren't necessarily all that compliant with wearing it. Rather than looking at randomized trials, there are lots of experiential data looking, for example, at clusters of individuals who were assigned mask use, for example, in elementary schools versus the same schools in that same relative area that masks were not required. And the relative incidence, for example, of COVID was up 59% in the unmasked group versus 8% in the group that had prescribed masks during school. And so there's lots of data like that. So the take-home point was N95, yes. If you're going to wear a mask, that's the one to do. When there's a spike in the outbreak, and people have to remember this, if we flash back to April of 2020, especially in large urban areas like New York, hospitals were overwhelmed, and we all had to do something to, remember the term flatten the curve. Well, there was a reason for that, because the hospitals were overwhelmed. And so they did work, the process worked, but it was harrowing for us to just kind of live through that indefinitely. So I think what we've learned from this is that mask work, isolation can work if we absolutely need it, but we have to be ready to take our foot off the brake and let people go back to living as much as we can once the immediate threat is resolved. And I'll finish with this comment that comes back full circle to RSV. You guys think back to 2020 when COVID came out, or especially coming into 2021. How much RSV did you see back then?
Yeah, and
Hardly any, right?
Yeah, the masking really suppressed that and
right
the paradigm there, definitely.
Yeah.
Yeah,
So,
there was definitely a shift in the epidemiology after mitigation measures were placed. But that kind of followed even then afterwards. We started to see the RSV season starting earlier and including older kids because they were not exposed the year prior. So last year was actually a pretty bad RSV season for us that started basically from summer to summer, really, until it finally calmed down. So it did change much of the epidemiology. And I think this year it's a little bit in between pre and post COVID for both flu and RSV.
that's a great point. I will make, George, one other comment. People ask me, when do I wear a mask? Now. Well, our numbers are down, so I don't think it's as prevalent in the world around us. But I'll tell you the place where it is quite prevalent, and that's on airplanes. And you say, well, wait a minute, why is that? And the answer is, it's not because of the air. The circulation's great on an airplane. The problem is people have flown somewhere on a vacation and they came down with COVID, and they're choosing not to stay in a hotel room for 10 days without knowing how they're going to do. They have no medical care. So they jump on an airplane. And most of them, people I know, do wear a mask, but some don't. And you don't know who's flying back with COVID. So there's a higher likelihood out of the general group of people who are flying who may well have active COVID who are on the plane. And the time we're most at risk of getting COVID on an airplane is boarding, but especially deplaning. When that little thing goes ding and everybody stands up at once and hangs in the aisle like crushed like sardines, that's a great time for transmission of COVID. The airflow is off. People are just right in each other's face. So that's a great time to wear a mask. So carry an N95 when you're traveling if you want to minimize your risk.
That's wonderful. Thank you.
I just wanted to add about an advantage to those research is that a lot of people were looking for evidence-based medicine behind masks and like, oh, where's the evidence? I think that all of these papers need to be published and read so that for future pandemics, we can use them and say, hey, this is our data, this is our evidence. Because unfortunately, a lot of people ask for that.
Yeah. And that JAMA paper, George, that you referenced, you're right, it was about 10 days ago. It's really wonderful. So it's in the JAMA Open Network, and it's free, as far as I can tell, online. So just type that in and use Google Scholar or something, you can go right to it.
Yeah, it was released October 31st. So JAMA Network Open, 2023. And then the other thing I wanted to close with is the use of Paxlovid in pregnancy, and at how it lowers the risk of adverse pregnancy outcomes in someone who has COVID and needs Paxlovid. That's something that, some people are worried about taking Paxlovid in pregnancy, but it's actually very beneficial.
Right. So a little bit of background on that. Paxlovid is a protease inhibitor. And for those who have been following HIV or hepatitis C, know that protease inhibitors are kind of the mainstay of each of these new therapeutic approaches. Not only that, it requires boosting with a drug called ritonavir, which came from the HIV world. But remember that women who were pregnant, who had HIV, would have months, years of treatment with a boosted protease inhibitor and a couple other drugs, and no adverse events when they're the ones that have been tested to the baby or the mom. So we have a lot of evidence that a boosted protease inhibitor can work. And remember, in the case of Paxlovid, it's just 5 days. So I think the biggest risk to a mom, it's just like with influenza. I can't give you the exact biology. Maybe it's increased blood flow through the lungs. Maybe it's an immune system change, that especially in third trimester of pregnancy. But pregnant moms in the third trimester in particular struggle with respiratory viruses, influenza, COVID, also to some degree RSV, I suspect. I don't know that for sure, but it makes sense. And so getting them on a drug like Paxlovid right away at onset of symptoms protects them from getting worse symptoms that require hospitalization and may actually even lead to death.
Wonderful. Any other comments, doctors?
I just wanted to make a comment on when you asked about symptoms, how to tell the difference. I think that, again, with the 3 circulating, you can have more than one together. So that also kind of reiterates that sometimes testing is really needed. And that's why also preventing these infections is also equally important as well.
Right. The beauty of the triple test is go to your doctor, you can get the answer right away, and you can have peace of mind. That's what they're there for.
Yep.
Anything else?
I want to just make just a general observation comment. All of us, doctors included, we tend to take science for granted. If we think back 100 years ago in 1920 or 23, we didn't have antibiotics to speak of. We had very few vaccines. Smallpox might have been the one. And kids were dying at much higher rates than we see today. And adults were dying. The average life expectancy was much less. Now, with COVID in particular, the speed of the development of all the therapies, the tests, the vaccine, was at a rate that was unprecedented. And for some who maybe are more the naysayers on social media said it was all too fast. Well, it took the time that it needed to show efficacy and benefit. And we should pull back and look at the big picture of this and celebrate the science, because it is amazing. And I would argue, but for the development of drugs, the understanding of how to treat severe disease in the hospital that has saved hundreds of thousands, if not millions of lives in the United States, and then the efficacy of the vaccine, especially in terms of preventing hospitalization and death. And we saw that most in January of 2021, in my view, because we tracked at University Hospital. I'm sure you did the same at USA. We tracked who was in the hospital and who was in the ICU. And invariably, it was 95 to 98% of people in both hospital and ICU who were unvaccinated. And the vaccinated people, for the most part, were not getting sick enough to go in the hospital, even though they might have symptoms. And so I think we should pause and just take some of the energy out of the anti-vax sort of thinking. The vaccine has saved millions of lives, hands down. And we should celebrate that fact and embrace it. And how many kids have you seen with Haemophilus influenza B infection, with epiglottitis recently? None.
None.
Right? And just the miracle of vaccines has just revolutionized survival in childhood and prevention of complications in adults.
Right. If one puts it in a historical perspective and looks at the 1918 pandemic and the impact that it had on our hospitals and the inability to count how many tens of thousands of people died in the state of Alabama, what just happened in 2020, 2021 is nothing short of miraculous.
It is. That's right.
Absolutely. Well, thank you all very much for this robust discussion. And on behalf of the Medical Association and the patients we have the privilege of serving, thank you for taking time from your busy schedules to provide our patients with really sound science